Welcome everybody to Geriatric Grand Rounds this morning. Thanks for joining in. A few announcements before we get started on our presentation. So there is no Grand Rounds December 31st. Our next Grand Rounds will be January 7th, and we're going to have two presenters at that time, Dr. Dory Miller and Dr. Matt Babcock, two of our postdoctoral fellows who will be giving us some updates in their research in progress. So please join for that. Our next journal club will be January 14th, and the presenters will be Dr. Tasmia Ahmed and Dr. Scott Pearson. A few other announcements. After Grand Rounds today, you will receive an email with a link to the recording of the presentation and a copy of the slides. Also included will be a link to an online evaluation, so please take a moment to fill that out and return that, as that's really helpful for our speakers as well as the organizers of Grand Rounds. Please submit questions in the chat or Q&A box during the presentation, and we'll have time for those at the end. And there will also be some questions as we go along, and please feel free to respond to those using the chat box so that we can try to have a little Q&A and dialogue during the presentation as well. So I'm pleased to introduce our speaker this morning, Dr. Tamanna Tiwari. Dr. Tiwari is a dentist, assistant professor in the Department of Community Dentistry and Population Health. She's associate director for the Center for Oral Disease Prevention and Population Health Research at the School of Dental Medicine here at CU. She obtained her master's in public health and global health leadership from New York University. She's funded for research by the National Institute of Dental and Craniofacial Research, as well as the Colorado Clinical and Translational Science Institute, DentaQuest, and Colgate. And she's going to talk to us today about oral health in older adults. So welcome, Dr. Tiwari.
Thank you. I'm going to share my screen. Can you see my screen? Carrie?
Yes, looks great.
Okay. So good morning, everyone. We're going to talk about oral health in older adults and the objectives. Oops. It worked fine when we were checking it. Let's try it this way. So the objectives for today's talk are oral health is about oral health as an essential component of overall health in older adults. We're going to look at some systemic and oral health interactions, and then we're going to look at the oral health of older adults in Colorado and beyond. So what is oral health? According to the new definition that came out from the Federation Dental International, oral health is a fundamental component of health. It is influenced by a person's changing experiences, perceptions, expectations, and ability to adapt to circumstances. Furthermore, oral health is multifaceted and includes the ability to eat, speak, smile, smell, taste, chew, swallow, and convey a range of emotions through facial expressions with confidence, without pain, discomfort, and disease of the craniofacial complex. And this, I was just talking to Carrie before we started, is so important right now, and you all must have felt it when everybody's wearing a mask, that you cannot see the expressions and emotions of the person in front of you, and it actually affects how you interact with them. And that leads us to quality of life. Oral health quality of life is in line with this new definition that I just told you, because it is a multidimensional construct representing how much oral health conditions affect a person's daily life. I mean, it affects what you can eat, if you can sleep comfortably without pain, how you socialize. So there are a lot of components that go into the oral health quality of life. Tooth loss is a critical indicator of oral health status and oral health quality of life. Tooth loss is also called as tooth mortality because a tooth endures a lot of health and disease ups and downs throughout the lifetime, and it may lead to loss of that tooth because of the higher disease component. I just wanted to show you about the percentage of US population by age groups and what's going to happen by 2050. As you see, a percentage of people under the age of 18 are going down, and as we see towards 2050, and older adults are on the rise. So I have one question for all of you. Why is oral health important in older adults? If you can answer in the chat feature, maybe a word, whatever you think would be really great so that I can see what you all think about oral health in older adults. Carrie, do we have anything?
Yes, so someone has said that it affects overall health, especially other chronic diseases. And then another one, infection, quality of life, eating, etc., correlation with cardiovascular health.
Great. That is a great start. Thank you. So oral health in older adults the WHO has described the main challenges of oral health in older adults, including tooth loss, dental caries, periodontal disease, xerostomia, denture-related conditions, oral precancer, cancer, and all these conditions are known to impair the quality of life in older adults. Risk factors, when you look at risk factors, the risk factors are almost same as any other chronic disease that you will see. And for your information, oral health in 2019 was included in the Non-Communicable Disease Alliance at the WHO level. So it is recognized as a chronic disease. So when we look at risk factors, the social determinants of health are as much applicable to oral health as they are to any other disease: stress, nutrition, access to care, smoking, whether you have insurance or not. And access to care is a really important component, especially if you are living in a rural area where there is, shortage of dental practitioners, or there might be dental practitioners who may not accept Medicaid. And so those could be an additional risk factors that a lot of older adults might see. Barriers to care: knowledge and attitude pertaining to the need for oral health care. So I want to emphasize the fact need for oral health care, especially when there is no pain, is because a lot of older adults might think that they may, tooth loss is a part of life, you're going to lose teeth, but that has changed in the past 25 to 30 years, and now there are very many ways to retain teeth and have a full dentition, so that so that people can have a better quality of life and better nutrition. A significant portion of individuals over the age of 65 do not view oral health as an important feature, as I said. Health beliefs, cultural practices, language barriers, social networks, they are a key reason oral health older adults may lack dental care. My research is with, I do a lot of research with children as well, and families. And what I see is that health beliefs is a really, really important component on what your perception is about what's your need to go see a dentist. And that trumps everything else up. And that's maybe the deciding factor of why a person may seek care especially when they have no pain. So my second poll is, what systemic diseases are associated with oral health or tooth loss? I think one was cardiovascular disease, someone else had said, but can you think of any other diseases, systemic diseases that might be associated with tooth loss? You can use your chat feature to let us know.
Okay, we have diabetes.
Mm-hmm.
2 people said diabetes.
Okay, yes, and we're going to talk about them a bit more.
Oral cancer.
Mm-hmm. Okay, so while we are at the questions, I just also want to know, have you heard the term functional dentition? Just let us know yes or no, because the rest of my presentation is going to talk about functional dentition.
We have a few no's.
Okay.
A few no's. I don't see any yeses yet.
Okay. So functional dentition and why should we care? Functional dentition is defined as an adequate number of teeth in oral cavity, which is considered necessary for maintaining function. Function. These are 20 natural teeth. So you must have 20 natural teeth to maintain function. The World Health Organization declared retaining at least 20 natural teeth as important to maintain function, aesthetic throughout life, and it impacts quality of life greatly and is associated with several systemic diseases. And I will talk about those in a minute. But from now on, I'm just going to talk about functional dentition. So I just wanted to make sure that we know that what does it mean. A lot of this work on functional dentition came out of Japan. They have a large older adult population, and also from Brazil. But now US has started doing a lot of work in this direction. And whenever it is possible to look, we do look if the patient has a functional dentition or try to maintain that at a clinical level. Functional dentition has been associated with cognitive abilities. There are a few plausible mechanisms. As I said, that this work has started to be used more and more research is being done. So that's why I'm talking about plausible mechanisms. There were animal models that showed masticator dysfunction caused by molar extraction and occlusal disharmony, and soft tissue, feeding induces pathological changes in the hippocampus and cerebral cortex. However, in humans, they've done some neuroimaging that shows that brain regions that are linked to memory and learning are activated during chewing activity. And that's why we talk about occlusal disharmony in the back of the mouth. We need to have teeth that are occluding. That helps in mastication. And masticatory activities have shown increase in cerebral blood flow and cognitive task performance. Indirect pathways, the dentition status can be linked to cognitive impairment via nutritional pathways. Now, in fact, the lack of functional dentition is related to inadequate masticative performance. That means nutritional intake will go low, we'll eat more processed foods, less intake of protein as well as fruits and vegetables. And I'll show you some research related to that as well. The association between nutrition and cognitive status is documented. So that's sort of the indirect pathway that we have. There were, although, there's also a bigger concept of bilateral impairment. The associated poor oral health and cognitive impairment can be bilateral. Patients with a cognitive impairment like dementia and Alzheimer's, they may have poor oral hygiene, more periodontal disease, and that may lead to teeth loss as well. And there are many confounding factors, aging, lifestyle, other systemic diseases, as you guys told me, diabetes, cardiovascular disease, and those are confounding variables. And so there is a lot of research going on in this direction to see how functional dentition is related to cognitive abilities. There was a recent, not very recent, but 4 years ago, systematic review and meta-analyses done. The results indicated that individuals with less than 20 teeth had a 26% increased risk of cognitive decline and 22% increased risk of dementia. And they looked at the pool results of all the studies that were included in this meta-analysis, and they saw that, the risk was about one, the odds or the hazard ratio was 1.2 for cognitive impairment, and dementia, it was about 1.2 as well, and it was significant. So I've included this study in the references if you want to have a deeper dive or a deeper look into it. Then we will look at the functional dentition and healthy eating. As I said, consumptions of fruits and vegetables is associated with having a functional dentition. There was enhanced data study done by Bruce Dye. He is now the co-scientific editor for the Surgeon General's report on oral health, which is going to come out next year. And they looked at males who had 21 or more teeth, consumed slightly more fruits and vegetables, as compared to dentulous males, and females with natural teeth, more than 21 natural teeth, had higher vitamin C intakes as compared to edentulous females. Overall, the results were that if you have if you have a functional dentition, or if you have prosthesis with a functional dentition, you may be consuming more fruits and vegetables. Again, to talk about that, there's a relationship between functional dentition and protein intake in older adults. And there was a longitudinal study which looked at older adults who did not have a functional dentition without dentures. Their BMI increased over a period of 1 year. There have been several other studies. One was a longer study done in New York as well that looked at BMI increases in older adults who didn't have a functional dentition and did not have dentures if they didn't have a functional dentition. Quality of life, there have been several studies, but I'm just going to talk about one systematic review and meta-analyses, which showed that tooth loss is associated with unfavorable oral health quality of life scores. Relationship between number of occluding pairs of teeth present and oral health quality of life had a positive correlation. As I said before, you may have enough teeth in the mouth, but we want to always make sure that older adults have good occlusion in the back of the mouth so that chewing is easier. And once that happens, your nutritional quality improves, and that is also related to your quality of life. Of course, impact of anterior tooth loss was very highly seen with socialization if they were not replaced. I'm going to show you some data from our clinical EHR. So we collect all the information in an EHR, which is not Epic, it's Axiom. A lot of dental schools use a dental EHR, and we have the ability to extract data from that and look at the population level health of the patients visiting our dental clinics. So, EHR extracted data from EHR for past 4 years for patients over the age of 60. Overall, SDN, School of Dental Medicine sees patients who have higher comorbidities as compared to the state. And about 40% of our patients are over the age of 55. This is sort of a breakdown. We had extracted data for, as I said, over the age of 60, and this is what you see, the simple breakdown of patients since 2017 till now that we extracted. And when you see the retention of functional dentition by age, you can see that, you know, the retention of functional dentition is going down quite in almost a linear fashion as you grow, as our patients grow older in age, which is understandable. So we did some analysis where we saw how many comorbidities are reported by our patients. None. We had one or two or more. And you can see that the odds of not having a functional dentition increase quite a bit as the comorbidities go up. Being a male increases the odds, and that is pretty much similar to the national data that we look at. And also being African American and Hispanic Latino also increases your odds of not having a functional dentition. And this is all data from our patients coming into school. Interesting fact that we had self-pay patients, and we also had Medicaid patients categorized. Having Medicaid was slightly protective for to have a functional dentition as compared to self-pay. And why is that? Is because Colorado provides Medicaid adult benefits, which do not go away after the age of 65. So a lot of our seniors who come to the dental school, they may have Medicaid, and they can get, till this December, they can get $1,500 towards their treatment, which excludes dentures. Dentures have a separate pot of money. That $1,500 has will come down to $1,000 next year because of budget cuts. But still, you know, we can get them in the door, look at what issues they may have, and at least provide preventive care for the future. So that is something that was interesting that I saw in the analysis. Looking at cardiovascular disease, diabetes, and tobacco use, you can see that the odds of having less than 20 teeth or not having a functional dentition go up. And for tobacco, it's really high up. We've done these analyses for since 2017 for separate years, for combined years, and the odds have remained pretty much the same. And I can show you the percentage of adults with less than 20 teeth reporting systemic diseases over a period of 4 years. The percentage almost remains same for both cardiovascular and diabetes, which is about 40 to 50% of the older adults report that, which as already said, it's higher than the state because our population that comes to the dental school has more comorbidities. When you look at trends of tooth loss reported along with because of systemic diseases, you look at the odds pretty much have remained between 1.3 to 1.8 for cardiovascular disease. They're slightly higher for diabetes, between 1.4 to 2.3, and this was pretty much the same that we have seen even before 2017. When we look at the trends in the percentage of adults who reported tooth loss due to smoking, the percentage you can see has not changed to 50-55%. Overall, we've seen since 2017. And here are the odds. I'm not sure why we had a dip in 2018, which is great that we did, but we see that the odds remain pretty much close to 2 to 2.5 of losing of not retaining a functional dentition if you have reported tobacco use. And our tobacco use in data collection is not just about smoking, it's about any tobacco use. So we collect all the information if you use chewing tobacco as well. So this gives you an idea about some population within Colorado. It is a more, not a very generalizable data set because it is taken from the dental school. However, does give you an idea how important is to maintain a functional dentition, and also how functional dentition or tooth loss is associated with different systemic diseases and with tobacco use, and the odds go up and up as you have one or more comorbidities. And just a caveat there that this data on CVD, diabetes, tobacco use is self-reported by patients. So it's not taken from their medical records. But I can show you something better. As Carrie said in my introduction, that I have some grants from DentaQuest. I'm looking at Medicaid claims data from a national repository, which is IBM holds that national repository for Medicaid claims, and you can extract data from there. So we extracted data from 2016-17, which is about 91,000 patients. And what we did was, remember, now this is claims data. That means we're not asking people, we're looking at claims. So it's not possible to, within a 1-year period, to look at functional dentition because we can't count their teeth. We can only look at codes that led to extraction of teeth. But we can also look at the ICD-9 codes, diagnostic codes, to see what systemic diseases were present in those patients. This is all anonymous, so we do get data which is, this data is from 13 states. I can't tell you which 13 states because it is anonymized. So here we are looking at predictive margins of race and age. So what we did, instead of just looking at age, we started looking at a combination of interaction between age and race. So if you are white and aging, what happens? What's the probability of tooth loss versus if you're African American or Hispanic and aging, what's the probability of tooth loss? And here you see that as you grow older, you're African American, or if patients are Hispanic, they have a higher probability of losing more teeth as compared to the white population. Here I have this in a table format. So we looked at 6 or more teeth loss, and it was the odds of losing 6 or more teeth by age and race. Again, you see that being female has a protective effect on the odds, which we also saw in our Colorado data that I just showed you. And interestingly, getting periodontal disease, periodontal treatment has a higher protective effect on odds of losing teeth. And when you look at comorbidities, you see as the comorbidities go up, the odds of losing teeth go up as well. We were able to extract what comorbidities we were looking at. So we had a larger data set. So we were able to extract all the other comorbidities, and you can see the odds go up for everything, for all comorbidities, and they're all significant. So we see a relationship between tooth loss and systemic health, even in the claims data set when we look at from that perspective. I would then like to talk about some clinical information as well. So the oral health manifestation of medications is there, and you might be able to see that as practitioners in your practice. Oral manifestation of medications. This is a CE course if you would like to take it. It's available, I think, till the fall of 2021. And this is a hyperlink, so you can click on it and go to the, I think it's offered by the American Association of Family Medicine. And it gives you a list of medications that have manifestations in the oral cavity. Some of the very common ones I included here: gingival enlargement, dry mouth, and hyperpigmentation. Let's look at dry mouth xerostomia, which is very common in older adults. Dry mouth is associated with over 500 medications. Drug-induced xerostomia occurs most commonly in older adults. What can you do when you see an older adult who may have xerostomia or dry mouth? First of all, understanding the clinical symptoms, the tongue and cheek sticking out, sticking to the oral mucosa, and then frothy, ropey saliva, lack of saliva pooling, atrophy of the mucosal tissue, and so on. Taste alterations, burning mouth, and what can you do when you look at these all these clinical symptoms? You can prescribe a high concentration of fluoride toothpaste. And why is that so? Is because fluoride toothpaste is going to reduce dental caries. Reduced saliva is known to cause higher dental caries because saliva washes away all the food debris and is really protective for teeth. So, and you may start, your patients may start seeing a lot more root caries. So when the gingiva kind of recedes, the periodontal ligament recedes, the roots may be, portions of the root of the tooth may be exposed in the oral cavity, which is a softer tissue as compared to enamel because it has cementum on it, which is softer, and that may lead to dental caries in the roots, and a lot of debris sticking in those areas, and it becomes harder and harder to clean. And if you have less dexterities, even harder to clean those areas, and those may then lead to painful dental caries that may ultimately need tooth extraction to be conducted. So fluoride toothpaste can really help. Artificial saliva substitute, chewing a xylitol gum can stimulate saliva and xylitol, because you don't want sugary chewing gums to be prescribed to older adults or to anybody for that matter. And refer them to a dentist. And why this is a really important point that you can do is because that will help them with overcoming that perception that they may think, oh, I'm going to lose my teeth, I'm getting older, it doesn't matter. A referral to a dentist can also help with dental anxiety. A lot of people do have anxiety from needles and from visiting the dentist, and referring them and letting them know that it is not such a painful process can help. And nowadays we have been starting to use a product called silver diamine fluoride. Does anyone know what silver diamine fluoride is? Carrie, do we see a yes?
I don't see any yeses.
Okay. So silver diamine fluoride is a product, comes in this little bottle, and that is, it has fluoride, of course it has silver, and what it does, it arrests caries on contact. So you have to take a dentist or I think in Colorado, because hygienists can work on the top of their scope, hygienists can apply that too. You just clean it, clean the tooth surface, and then take a dab of silver diamine fluoride and you put it at the carious spot. It arrests caries on contact in any tooth structure, whether it's enamel, dentine, or basically does an enamel or cementum. And so it has been used a lot since the past couple years, but a lot more this year because it does not produce aerosols when you are using that process. So if older adults are hesitant to go to the dentist, they think it's going to be not safe or going to cause aerosols production right now in the COVID era, it is really a helpful magic bullet. There is a downside of it, that it will turn that spot wherever you put the silver diamine fluoride black because of silver. But if it's a posterior area which is not being seen in the roots, you can use it right. I mean, it can be used right now, and then later on, an aesthetic filling can be done over it. But the usefulness of that material, especially with someone who has xerostomia or dry mouth, is that caries can be arrested in incipient and really when it starts. And that is something that will be really helpful for the older adult population. It is also being used in kids in primary teeth and has been a very important tool in stopping the disease in its tracks, especially when nothing else was being done. So what else can you do in addition to improving oral health of your patients is recognize that oral health is a part of multimorbidity, consider its impacts on general health and quality of life of oral adults. I hope I have done a little bit of a job in convincing you that it is a really big part of general health and quality of life in older adults. Reflect on current medication regimes and see, if they are causing any oral health manifestations or oral manifestations. Perform an initial assessment of oral health, doing simple, just looking inside the mouth and differentiating between normal and abnormal findings. Also demonstrate oral hygiene measures to older adults and their caregivers in assisting if they have to assist to provide any oral hygiene. Decide when to refer to a dentist. And work in a collaborative practice. If you know where the person is going to see a dentist, pick up the phone, talk to the dentist, and so that the care provided to the patient is really comprehensive. Lastly, my other question to you is, what do you think you need to improve the oral health of the patients that you see? Do you need more training in didactic form, in clinical form? It would be good to do some hands-on experience in how to conduct an oral health exam. I mean, from the School of Dental Medicine, we will be very happy to provide additional training, whether it is clinical, didactic, in any form, so that may help you to then care for your patients much better. And I think with that, I'm going to close my presentation. Thank you very much. And we can have some time for a discussion and for Q&A.
Great, Tamanna, thank you so much. That was wonderful. Have one question in the chat box right now, which is, should we be advising Q6-month prophylactic visits into older age, or is an annual visit adequate?
I think a Q6 months would be really good if they are able to go. Now, this is going to depend on, the mobility of the patient, the access to care. I mean, if they live in Western Slopes and they have to drive 4 hours to reach a dentist. So those things will be a factor. But if they are able to go, Q6 is good. But once a year, I think, is really, really important.
And then add on to that is whether there are any saliva stimulation products that you favor for xerostomia, for example, biotin versus anything newer or better.
No, biotin is still is considered a really good product for saliva stimulation. But what I would advise if your patients do have xerostomia or dry mouth, you may want to look in their mouth and see if they are starting to develop dental caries. And so then your referral to the dentist should be sooner, because that's going to really stop the disease before it becomes a really painful event in their life. You have any more questions? So yeah, go ahead, Carrie.
No, I was just going to say I don't see any new questions. So
okay, so then let me know about my question to all of you guys. What do you think you need more to help improve the oral health of your patients? So for example, we have been discussing to do a hands-on experience, a hands-on oral health exam. It was not possible this year because of all the social distancing restrictions, but we have been thinking we could do it via Zoom, where we might be able to have one patient and a dentist do the exam and show it to you in that format. Would that be useful?
we do have a comment here about something that would be useful would be referral to low-cost dental care. I know that's a barrier to a lot of our patients.
Right. Actually, so you can refer them to the school. There are a few clinics that do sliding scale, and Carrie, I can send you the names and phone numbers for those if you want to keep those.
That would be great. Yeah, thank you.
Yeah, and there are some of them are in the Aurora area, so that may or may not be useful, but I'll send you that information. You can always refer them to the school. We do that. We did in the school used to have a grant as well for older adults, which was coming through the state. I will have to check if we are going to get it next year. You know, a lot of things have been changing with budget cuts. But those are a few places that I can definitely send you the information for.
Thank you. A couple other comments in terms of needs is someone commenting it would be great if a few dental sessions could be included in the fellowship. So this could be part of the training for our geriatric fellows. And then along with that, do you think having trainees spend, a half a day in clinic is feasible once COVID clears?
Yes, and that has been a discussion of ours. We have a oral health advisory committee, and our dean is involved in it, and she's really interested in doing this collaborative work. And we will start that as soon as we can with all the restrictions that are going on right now. But that has always been on our radar. We have been in contact with, the Center on Aging and a few researchers to see how we can actually make that happen. So that is on the books.
Great, thank you. Any other questions?
Okay, I don't see any more questions, so thank you very much. I will send out a more update. This PowerPoint presentation is more updated than what I sent to Paul yesterday. So I will send it out again, and it has my contact information as well. So please feel free to contact me if you have more questions about the research or about your training, and we will see what we can definitely do to help you improve your patient's oral health.
Great. Thank you so much. It was a wonderful presentation, very informative. And everyone, thanks for participating. And please look for that email with the link to the presentation as well as the evaluation. Have a good holiday, and we'll see you again when we resume in January. Thanks, Tamanna.
Yeah.
All right, bye-bye.